All right. Well, Dr. Ostrosky, thank you so much for joining our podcast. I guess we were both having technical difficulties last time, so I know you were having issues with your computer. We were actually just having issues with
Camera.
our camera. So
Well,
I'm glad it all worked out. Um,
uh, mhm.
so for our listeners, can you introduce yourself? Tell everyone where you work and your background.
Yes, my name is Louis Ostrosky, and I'm the current professor and chief of the Division of Infectious Diseases here at UT Health. And I'm also the medical director for epidemiology for Memorial Hermann, Texas Medical Center. And I've been working on COVID-19 for the past 2 years now, advising the university, its affiliated hospitals, and many other organizations around town.
Perfect. I appreciate that. What prompted us to reach out to you, doctor, is because there was an article in the Houston Chronicle highlighting the negative effects of obesity related to COVID. And we haven't really heard a lot about this until that article. It's not widely populated. It's more maybe so talked about, maybe more underground news, but not really publicized in the major media outlets. So can you talk about that? And why is it not really widely talked about and known that obesity is such an issue with COVID-19 patients?
Yeah, no, this is a very good point. So ever since the pandemic started, we actually have been keeping track of conditions that put you at higher risk of morbidity, again, getting sicker from COVID-19 and mortality, dying from COVID-19. And it's been kind of a running list since March 2020. And, we know that things like heart disease, obesity, diabetes, being immunocompromised, having breathing issues, having other heart issues that are not necessarily sort of considered heart disease, congenital malformations, developmental issues for kids. All of those are the risk factors for having a bad course of COVID. So obesity has been actually there from the very beginning. We've noticed that ever since our first cases, we saw some people were morbidly obese, and those people tended to do worse and die more often. And it's really just kind of getting lost in the sort of in the list, right? So obesity was one of the first comorbidities reported again almost 2 years ago. And people always say, well, there's obesity and there's morbid obesity, and I'm not that fat or whatever. But even, small increases in your BMI over 25 will put you at high risk of this disease. And now we have some data sort of now basically exploring why obesity is such a risk factor. And it turns out that there's some increased sort of replication of the virus in fatty tissue, et cetera. So now, aside from an association, we have a little bit more of a understanding as to why obese people may be at higher risk.
It's pretty crazy news. Mike and I were looking at some articles this morning, just to stay current, and it's almost 40% of Texans are considered obese, and Texas actually ranks, depending on which chart you're looking at, just for per capita instances, Texas ranks in the top 20 for obesity. Is there anything that medical professionals are doing to highlight that, or to bring education awareness, diet awareness, physical health awareness? I mean, what are we doing as a state to combat that?
No, for sure. This is a very important trend here in Texas. We have extremely high rates of obesity. We have extremely high rates of diabetes, for example, as well. And then the cousin heart disease goes together with those two. And it is, again, well known that this is a demographic issue in Texas. We have a very high proportion of Hispanic communities, African American communities, and those communities have baseline higher rates of those issues as well. So we're the unfortunate product of our demographics and our diet and our sort of way of life here in Texas. And again, we have put out a lot of education as far as obesity and COVID go, and heart disease, diabetes, and the health departments do a lot of sort of work on that as well. It is another epidemic here in Texas, not only COVID, but obesity, diabetes, and heart disease.
I saw something in the paper where obesity is more prevalent in lower education communities. Is that accurate? Like the lower the education of people, the higher the obesity rates are. Is that fair?
That's kind of a very complex question. I think obesity is prevalent throughout all socioeconomic strata here in Texas. But yeah, when you start going into sort of marginated communities, they have, of course, lower education regarding what a good diet is, lower access to nutritious foods with this food desert sort of concept, lower funds to purchase good quality food as well. So it's a very complex issue, but yes, we do see higher rates of obesity in our marginated communities.
How was the feedback on the article that came out? Did you get any negative or positive feedback from that?
Oh, hey. This podcast episode is brought to you by BCN Supplements. BCN Supplements is a Texas-based company that produces and manufactures everything right here in the great United States of America. The good thing is BCN caters to every single person on the fitness spectrum, whether you're a seasoned hybrid athlete, kind of like myself, or you're a newbie just now starting to pay attention to your health, kind of like Mike. BCN has what you need to make a healthy choice. Lately, I've been using BCN's pre-workout mix, and to be honest, I'm not really a pre-workout guy because I don't like the way most on the market make you feel. You know, the crash and that tingly feeling, but you don't get any of that junk with BCN's pre-workout mix. I've noticed I had more focus during my lifts and more energy to carry through my longer workouts. And that pump you get is just, it's amazing. Drop what you're doing right now and go to bcnsubs.com to place your order today on this pre-workout mix. They got vitamins and they got collagen, and be sure to use promo code CWJM to receive 10% off your next purchase. BCN Supplements, helping build a better you from the inside out.
No, I think, again, for most medical professionals, it's not big news. It's kind of, we've known this since the very beginning. And the community perhaps was a little bit surprised. But again, it's kind of, just another byline in a table that talks about risk factors for obesity for COVID for most people. And the other thing that we see is kind of this mentality of, oh, it's not my problem because I'm not obese or I'm not that obese. And again, just a small increase over a normal BMI may correlate with severe illness. So you don't need to be morbidly obese to be at increased risk. And it may be a modifiable risk factor, right? So like if you worked on losing weight, you would sort of take away this risk from yourself.
Scientifically, can you explain to everybody why obesity puts you at such a risk? What does the virus do to your fat cells or, your body if you're obese? How does it replicate so fast?
Again, there's new data showing that the virus can replicate and perpetuate in fatty tissue. So again, obese people may, of course, naturally be more prone to have continuing replication and higher levels of virus in their body. But the other thing that happens with obesity is kind of a functional issue where, again, with the comorbidities of obesity, you have lower respiratory capacity, lower heart reserve to sort of withstand a big sort of shock to your system, lower conditioning, etc. So the combination of both things is probably what's driving the bad outcomes in obese people.
Okay. There's a lot of talk of natural immunity versus the vaccine shot. So what can you tell people? What is superior? Because it's almost like a political divide. If you're on one side of the fence, natural immunity is king. And then if you sit on one side, vaccines are the king. So it's very confusing to normal people who are not, staunch Republicans or Democrats. What guidance do you have for normal people that aren't on either side of the fence?
Yeah, so it's really unfortunate that there's a divide over scientific facts, basically, and there's a lot of misinformation out there, and misinformation that looks very very professional from reputable sources with people with degrees and titles, etc. But the facts are that you can actually get immunity both ways from the vaccine and from natural infection. The problem is that immunity from natural infection lasts a lot less and is a lot less sort of predictable as to how high it's going to be and how long it's going to last. It's also less broad in the repertoire of viruses it would cover. It would cover you primarily for the one virus that infected you at that particular point in time. So because it's so unreliable and so variable, we recommend vaccination because vaccination produces reliable immunity levels, longer lasting, and it is broader in the spectrum of activity of the antibodies that we create. Now, it turns out that the very best thing to happen to you, if it happens to you, is to actually be both vaccinated and have had the natural infection at some point, because that creates a very highest level of antibodies you can have and will protect you more reliably against future variants as well. But by no means it's a strategy we recommend is to get vaccinated and infected, right? Because again, there's a chance you may die from natural infection.
I'm sure you're familiar with Dr. Peter McCullough's work in Dallas, and he recently did a podcast with Rogan talking about natural immunity versus vaccines, and he stated something along the lines, don't quote me on this, but the vaccine only produces one protein barrier versus natural immunity kind of covers all the proteins that is when you contract the virus. So is that completely false? Did he completely lie or stretch the truth about that? Or
it's a little bit stretched. Again, you create multiple levels of antibodies with the vaccine as well as with natural infection. And what we know is that the ones that you create with the vaccine are longer lasting and more reliably sort of broader and basically are going to cover people better. So hence, we continue to recommend people get vaccinated and not rely on a herd immunity strategy to get through this pandemic.
okay.
What do you think about the people who've gotten either one or the two vaccines plus the booster and they're still getting COVID? How does that happen?
Well, unfortunately, with both the Delta variant and Omicron now, they're changing enough that they're escaping the vast majority of the antibodies that are being created by the vaccines, even the boosters. The vaccines are still doing their primary job, which is to protect you against mortality and getting sick and ending up in the hospital. But we are seeing a lot more breakthrough infections, particularly with Omicron now. This past weekend, I spent the whole weekend, talking to people that were fully vaccinated, boosted, and went to a holiday party this past week and got infected, right? But they're doing well. They have mild illness, but they're having mild illness because they're vaccinated and boosted. And I'm sort of reassuring people that you're very unlikely to land in the hospital under those circumstances. The problem, again, is primarily for the people that are not vaccinated or boosted at this point.
Can you talk about the length of protection with the vaccine and natural immunity? Because we're seeing, news stories as, we need a third booster. I think there's some countries even considering a fourth booster or a second booster, totaling 4 shots now. So what's the actual length that a person can expect from contracting the virus naturally versus a person that's been vaccinated?
That's actually the problem. Some people that get infected naturally don't even develop antibodies. Some people develop antibodies that last 3 months, and hence some of the language initially about 3 months after you have the virus, you can avoid getting vaccinated, or we don't even test you again for 3 months if you had an infection before. But some people don't make it to the 3 months. Some people do 5 months. Some people do 7 months. It's really variable. With the vaccine, we know that most people start having a decline in their antibody levels at about 6 months, 6 to 8 months. and we know that the booster restores that. Currently, we're only recommending a fourth shot for people who are immunocompromised, people that have immune deficiency or are in medication that sort of thwart your immune system. And those people get 3 shots basically as a primary series, and they get a 4th shot as a booster 6 months after the 3rd shot. Again, whether we're going to be needing boosters every 6 months or every year, it's too early to tell, because we're learning as time goes by, and at this point, there's not a lot of data for a year out after you've been vaccinated.
Yeah, it's so confusing for us normal people, doctor, because we hear you talk and we hear you saying, and not just you, other medical professionals discuss the positives of vaccinations, and then we hear these one-off doctors talk about natural immunity is the king, and then I think we've even heard people say once you contract COVID, you can't contract it again. Is that false as well?
It's completely false and inaccurate. I can tell you the thousands of people that I've seen in our hospitals here that have had COVID early in the pandemic and have had it a second time and now even a third time. Yeah.
Okay.
Oh, wow.
That's pretty intense.
And with the Omicron, we're kind of hearing it's a lighter form of COVID thus far, and you're in the heat of everything. So, I mean, is that kind of the case? What you're seeing, is it kind of a dull version of COVID, or have you seen strong cases as well?
So we're hearing anecdotally from South Africa, where we first noted the emergence of Omicron, that the cases appear to be milder, particularly in vaccinated people. And then again, that's anecdotal at this point. We hear from our colleagues in South Africa saying that. And we see the data in South Africa where, the number of cases are shooting up, exponentially, and the hospitalizations are increasing, but not in the same proportion as the number of cases. So that's very comforting, right? But now we're hearing data from Europe where, Omicron appears to be as sort of damaging and severe as Delta has been. So I think the jury's still out. We cannot rely and say, oh, Omicron is not a big deal. We're watching Omicron very carefully. We are seeing currently in town a lot of cases. 82% of the COVID-19 isolates here in town are now Omicron. And again, you see a lot of people breaking through and having mild disease, but we won't really know if it's severe disease until 2 weeks, because the people that get sicker are going to need about 2 weeks to get sicker with pneumonia and land in the hospital. So for us here in town, the real test is going to be in 2 weeks.
What about, so we got here in the U.S., we have 3 main vaccines. We got the Moderna, Johnson & Johnson, and the Pfizer. Recently in the news, the CDC came out and said, if you can take Moderna or the Pfizer, because Johnson & Johnson causes blood clots. And then like a day later, we saw that Moderna causes a lot of myocarditis, and even the other, is it pericarditis around the heart? Is that what it's called? And then so now the CDC is saying Pfizer BioNTech is the way to go. Is that the message here in Houston as well?
Okay, so we've always known about the risk factors for clots regarding both Johnson & Johnson and AstraZeneca that's not available here in the U.S. And I think over time, CDC has concluded in their analysis that even if the incidence of J&J blood clots is very low, why risk it if there's other vaccines available? And that's, I think, the driver behind the decision to preferentially sort of recommend Johnson & Johnson. We also now know that 1 shot of Johnson & Johnson perhaps is not enough. They recommended to basically everybody that got Johnson & Johnson to get a booster after 2 months of their shot, not 6 months. So it's turning out to be that Johnson & Johnson may not be the ideal vaccine. And that's why this shift in language from the federal agencies. As far as Moderna and Pfizer go, Both are extremely safe. Both have a risk of myocarditis, which is an inflammation of the heart muscle, and pericarditis, the lining of the heart, extremely low. Most of the time when it happens is self-limited and people do well. That they self-resolves without much treatment. And by far, lower incidence of myocarditis and pericarditis from the vaccine than from actually having COVID. You can also experience myocarditis and pericarditis. There's some very sort of detailed analysis showing the odds of getting myocarditis from the vaccines or from COVID, and it's much lower from the vaccine. So the federal agencies continue to recommend Moderna and Pfizer equally. No distinctions.
Okay. What's the risk factor in getting myocarditis or pericarditis? Is there something that stands out that a normal person can know? Like, I probably stand a good chance of getting this, or is it kind of sporadic?
It's thought to happen more frequently in young male adults and adolescents. That's kind of where it's starting to show up more. But again, this is one of the highest risk populations for getting COVID, right? Like teenagers and young adults. So again, they've done very detailed analysis showing the incidence of this rare side effect, the incidence of the rare side effect when you get COVID. And in every analysis, the vaccine wins. Lower risk from getting this from the vaccine than from the disease itself.
What about the so on the kids? What's the push, or is the risk greater than the benefits or greater than the reward? And if kids have a low chance of contracting the virus and ended up in the hospital, why do we need to vaccinate the kids?
Very good question. So, first of all, kids don't have a lower risk of contracting the virus. They have the same risk or higher than adults. Now we know that for sure. They do have a lower risk of ending in the hospital, severe disease. But nevertheless, in the past surge in the summer, we had hospitals full of kids with COVID-19 that should not have gotten it because now COVID-19 is a vaccine preventable disease. So whenever people bring this up, I just ask them, so what is the acceptable number of kids that's going to die in the United States?
Right.
And if you can answer that, I will tell you whether we should vaccinate kids or not. The answer for me is very easy. I don't think it's acceptable for any one child to die from this disease. And that's why we sort of are pushing forward with vaccinating kids. There's also a community benefit where kids may be spreading the disease in the community to adults and vulnerable adults. So it's basically a win-win to be vaccinating kids. The kids themselves are protected from dying, and we're protecting the community for increased transmission.
Yeah, and it's confusing because we hear that asymptomatic symptoms don't spread. If you're asymptomatic and you have COVID, then you're more than likely not going to spread it. But is that false too?
Completely false. That was one of the things we didn't know at the beginning of the pandemic. We didn't know if asymptomatic people could be transmitting COVID or not. And now we know that, basically 2 days before you're symptomatic, you're highly infectious. And that's what's driving a lot of the transmission currently.
It's tough.
So you feel well and you're going to your party and to work and doing your stuff, and you're actively infecting people.
What about therapeutic treatment? Is the vaccine the only way to combat COVID? With monoclonal antibodies and all the other therapeutic treatments that are available. Are we doing both simultaneously, or we only trying to push the vaccine?
We're working at all fronts. So yes, vaccines are incredibly efficacious in preventing hospitalization and mortality. If you're vaccinated currently, you have a 6-fold increase in your likelihood of not getting infected, and an 11-fold chance increase in not landing in the hospital compared to somebody who's not vaccinated. So very powerful protection from the vaccines. If you don't get vaccinated or you have a breakthrough case, we have monoclonal antibodies. Those are lab-grown engineered antibodies to go and neutralize the virus directly. And they were working fantastically well before Omicron. Again, about 90% chance that if you receive an antibody, you were not going to land up in the hospital or dying. So a very good sort of second line of defense. But with Omicron, we're starting to learn that at least the two main products that we use currently, which are the Regeneron product and the Eli Lilly product, either don't work or work much less efficiently against Omicron. So we're losing those at this point in time. There's a third product that's called the GSK product, Sotrovimab, that appears to cover Omicron, but it's currently in very limited supply here in the United States. So we're losing kind of our second line of defense at this point in time. And then there's two drugs that are under review by the FDA, one by Merck and one by Pfizer, that have shown, again, efficacy in avoiding hospitalizations and avoiding mortality, with some side effects and with some drug interactions, both of those drugs. And they were primarily studied in unvaccinated people. So we don't know what additional benefit they would have for somebody who's vaccinated or somebody who's received a monoclonal that works. But yet again, I always say that these oral drugs, if they work against Omicron currently, are going to be game changers, because monoclonals are very, very difficult to administer. You have to have an appointment, have an infusion or injections, and this would just be something you pick up at your drugstore and take, and have a very low likelihood of getting admitted or dying from this disease. So especially, again, if you're vaccinated, even if you have comorbidities. So that's kind of our arsenal at this point in time. Vaccines continue to be the best. Monoclonals were very effective at some point, but they're not so effective anymore with Omicron. And the two oral drugs are not FDA cleared yet, and they have some issues that are going to have to be discussed.
Okay. In regards to the monoclonal antibodies, does it matter when you get treated with those? Like, say if I'm feeling sick and I test positive for COVID today, will it benefit me to get treated with monoclonal antibodies sooner rather than later, or does it not matter?
Absolutely. We've learned, again, during the past 2 years, that there's basically three phases to COVID. The first phase is what we call the viral phase, where most of the activity and damage is being done by the virus itself, replicating and invading tissues, and the sort of the very immediate response to the virus. So that's the viral phase. And that lasts about 5 to 7 days. Then there's a phase where, the virus is starting to go away, but your immune system starts getting a little bit crazy after the virus. And you start experiencing some inflammation in your body, in your lungs, etc. And then the immune system takes completely over and goes haywire and starts attacking your lungs directly and your other tissues, brain, etc. So it turns out that antiviral strategies only work in the first phase, in the first 5 to 7 days. And that's where we need to use the monoclonals. That's where we need to use remdesivir, which is an IV drug that kills the virus. And that's where we would need to use these two new oral drugs that are about to be cleared. So again, sort of waiting around and seeing if I get better, or taking vitamins or not approved medication in this stage is a particularly critical mistake, because delaying care will result in progressing to the other phases of the disease. And by the time you end up in the hospital with inflammation in the lungs and requiring oxygen, we have very little interventions for people at that point.
Would you so if someone were to get fully vaccinated, with the exception of the booster, and maybe one of these people had gotten myocarditis, with the regular vaccine, would you recommend them getting the booster, or would they be just as likely to get it again with the booster?
Currently, the CDC only sort of mentions having active myocarditis from the vaccine as a contraindication to get the second dose or the booster. Of course, that has to be a discussion you have with your doctor and weigh your own personal risk and benefits according to your lifestyle as well.
And then in this day and age, when people come into the hospital now that are unvaccinated, how likely are they to be hospitalized at this point? Like when they come in, are they immediately hospitalized, or do they do some treatment and go back home? What is it looking like these days?
Yeah, so our typical patient who's hospitalized now with COVID in our hospitals is going to be most likely an unvaccinated person. About 95% of our hospitalized patients currently are unvaccinated. So most likely unvaccinated. They're going to show up a little bit late in the course, again, because they delayed their care and tried other things, etc. They're going to end up with a lot of lung inflammation and heart issues, etc., clotting problems as well. And about 90% of them are going to not required to be intubated or needing an ICU care. They're going to get, breathing treatments and some anti-inflammatories that we have in the hospital and be able to go home with oxygen and prolonged care. But about 10% of them are going to end up in the ICU with a very prolonged length of stay, and unfortunately, a lot of them die.
Are those remaining 10%? Are they normally the ones with comorbidities, or have you seen healthier people go in that 10% as well?
Yeah. So again, they're mostly going to be people with comorbidities, but we see completely healthy people all the time with COVID in the ICU. I mean, if you sort of read the news, you've heard about our firefighter, we've had a pilot, we've had athletes, young people who are completely athletic. Big tragedies, big tragedies, people that could have gotten vaccinated and were misinformed and chose not to vaccinate and end up, with a 4-month hospital stay, 6-month hospital stay, some of them dying. So I tell people, don't be a tragic story, just get vaccinated.
Yeah. And have you seen anybody that's been fully vaccinated that's been in the ICU, hospitalized?
We see people rarely in those situations. Most of them have multiple comorbidities or have problems in their immune system where they did not respond to the vaccine at all, like cancer patients, transplant patients, etc. But again, occasionally we will see somebody who's seemingly healthy and got fully vaccinated land up in the ICU as well. It's rare, but we see those. Mm-hmm.
I'd be remiss if I didn't ask you about the forsaken I word, ivermectin. What the heck is up with ivermectin, and why is it so bad? Like, why do people shun it so much? Because it's proven to work a little bit against COVID. Is that something that Houston doctors are using to treat along with monoclonal antibodies or not?
So ivermectin is an anti-parasitic drug. It kills parasites very, very effectively. We use it all the time for some parasites that you get actually here in Texas from walking barefoot. They go through your skin and your feet and replicate in your body and end up in your lungs, etc. Excellent anti-parasitic drug. Whenever there's a pandemic, people start testing, any drug we have currently on the shelf against the pathogens that are sort of in question to see if anything we have would work remotely. And that's exactly what happened with ivermectin. In the petri dish, in vitro, in the lab, concentrations that are thousands of times higher than a human would tolerate have modest activity against the virus. So again, you would need to give doses that basically would shut your whole system down your liver, your brain, your kidneys, to be able to get activity against coronavirus. But people say, if there's any chance that will work, why not, right? But that's not scientific thinking. That's not, medical thinking. It's kind of a very simplistic way to look at things. So we start seeing people in the community using ivermectin, some doctors giving it a go. And again, with coronavirus, most people do okay, right? I mean, we've talked about this. Most people with coronavirus, about 90% of people, are not going to land in the hospital. They're going to be okay with it. So in your clinical practice, if you start giving ivermectin and you see that most people do okay, you're going to conclude that, ivermectin works pretty well in preventing this. But the reality is that it doesn't. It doesn't do anything for these patients. And what we recommend is for it to be tested in a clinical trial to see if it actually gives any benefit. And we're actually carrying out a clinical trial currently that we're participating in, where we're randomizing people to ivermectin or placebo, which is the only way to really test whether it works or not. There's some people that say it has some anti-inflammatory activity, etc. Again, those are all big stretches. And at this point, I would not recommend anybody use ivermectin outside of the context of a clinical trial where you're being monitored and you're contributing to science. Because people that go directly on ivermectin are basically delaying care, again, delaying monoclonals or getting remdesivir or getting the new antivirals that are coming out, which is going to be to their detriment. And the other thing is that people are doing some funky things with ivermectin. They're getting sort of animal grade ivermectin at doses that are not for humans, and they're extremely concentrated formulas. And when you think you're diluting it correctly, but when things are so concentrated, even a small decimal error will result in a massive overdose. So what we have seen is people with ivermectin overdose and side effects in the hospital. There's even been deaths, intoxications, etc. So we are not recommending using ivermectin outside of the context of a clinical trial.
I'm interested in this clinical trial. You said that people were going to be randomized both unvaccinated and vaccinated, comorbidities and not. Is that being held only here in Houston, or is that across the United States?
No, it's a national clinical trial called the Active-6 study, which is run by NIH, where we're taking all the drugs that are sort of out there that may or may not have any benefit over COVID-19 to once and for all test them conclusively and say there's a benefit or no benefit, right? So patients get assigned to either ivermectin or placebo, or this other antidepressant, fluvoxamine, that has some activity. Again, fluvoxamine or placebo. There's a steroid that people take as well. They get the steroid or placebo. And we follow these patients very carefully. We see if they have side effects, and we see if they end up hospitalized or with mortality. And those are the endpoints for this study. And it's kind of a really cool clinical trial. You just sign up online, and we talk to you. We ship the medication to you or the placebo to you, and you fill out an electronic diary every day, detailing your symptoms and what's happening to you. It's kind of a very modern clinical trial we're doing.
No, that sounds pretty neat.
But you have to be sick, right? I mean, you have to have COVID.
You have to have COVID and symptoms of COVID. Yes.
It'd be kind of scary to be on a trial. You probably just want to get better.
Well, it's justified because we actually don't know that those drugs work at all or not. So that's the only situation where you can have a placebo in a trial. There was no other approved treatment orally at this point or inhaled. So it's kind of the way science works. When there's no other treatment, you test a treatment that may work against placebo.
One other thing being in Texas, doctor, that we hear about is the VAERS report. how much weight can we put in the VAERS report? People dying from getting vaccinated, getting the myocarditis, extreme cases, prolonged 6 months cases. How much weight can we put in that website?
Okay. So I'm going to start off by mentioning that there's never been a more highly scrutinized rollout of a vaccine in the history of humankind. If you want to participate in VAERS, you get your vaccine, you get a link to download on your cell phone, and every day you get a prompt about your symptoms and what's happening to you. They ask if you're being hospitalized, if you have any medical issues, and you should know that if you actually report having a problem, somebody calls you and asks you what the problem is, and they try to get your medical records and investigate the key question, which is this related to the vaccine or not, right? So again, massive rollout of the vaccine, massive surveillance program, and the VAERS program is working because that's how we notice myocarditis, and that's how we notice blood clots. And it's a very, very interesting analysis to sort of try to tease out what's related to the vaccine to what was actually going to happen to that person anyway. Because we're watching them, we're watching millions of people, events that were normally going to take place happen, right? And you have an analyst that's actually determining if this event, is related to the vaccine or was something related to you or your medical history. So for example, in clinical trials, again, we do this all the time. You give a patient a medication or a vaccine or an intervention, a type of surgery or whatever, and you're following them for a year after you gave them an intervention. Somebody gets run over by a car and dies, unfortunately, and you have to report that as a mortality in the clinical trial. So in certain analysis, that's going to show up as somebody dying from your drug or your intervention because they died in the sort of vigilance period, right? But when you attribute the mortality, you say, well, yeah, there's no way this car accident was related to the study drug that was given 8 months ago. That mortality goes away, and it's only the adverse events that are related to the study drug temporarily or by a mechanism that get counted, right? So again, many ways to analyze data. You should know that there's a lot of people working in this analysis, and the proof that it works is how we notice that myocarditis and blood clots are related to the COVID vaccines.
So it's regular people or patients that received the vaccine putting in the information into the VAERS report. There's no medical professionals intervening and doing it for them.
It goes both ways. You're asked to report anything yourself, and we're also expected to report any adverse event that we identify that's related to the vaccine. Okay. As medical professionals.
Yeah, that report has become talking points for both sides of the aisle, right? I mean, it's for someone that's unvaccinated and against the vaccine, they cite the VAERS report, which may be, wrong or incorrect, and some people that are for the vaccine, they're saying that it's misleading information because it's regular people putting it in. So, as someone who's kind of middle of the aisle, it's very confusing for us regular people.
Yeah. Again, the problem we have is that we have this distrust in the government and the institutions that are working this report. Again, I'm going to tell you that there's legions of scientists sifting through that data and sort of calling people and getting medical records and seeing what is and is not related to the vaccine. And that's how we identified myocarditis and clots. That's the proof that the VAERS system is working.
Okay.
Mm-hmm.
I had as a kind of a controversial topic, but I just wanted to kind of clear the air. We heard in the early days of like incentives to document like COVID cases or the use of ventilators and things like that. Is that real information? the hospitals are getting paid incentives to document COVID cases or test every amount of tests that they conducted. They get paid a certain amount. Is that real information? I know we heard that in the early days.
Completely false. Completely false. Yeah. There's no incentive to document the COVID case. There's no incentive to test people randomly. The last thing you want is your hospital full of COVID because it impedes every other operation in your hospital.
It's crazy how propaganda can just start, because I mean that's what everybody thinks. It's really traveled quite far.
Unfortunate. Yeah.
What's the landscape for Texas look like, Doctor? What do the hospitals look like? We've heard recently that there's been a rash of nurses been suspended for not getting the vaccine mandate. Now we're seeing reports of hospital beds filling up due to Omicron. So are we, first off, how severe is the nurse shortage here in Texas?
We are experiencing a national staffing crisis in hospitals, primarily driven by, number one, fatigue. People are completely exhausted of dealing with this. It's physically and emotionally draining for doctors, nurses, radiology technicians, phlebotomists, administrators in the hospital to be dealing with surges of COVID where all you can do is take care of COVID patients and other people suffer, other people with other diseases don't get the care that they need because there's no beds, or we have to cancel surgeries, etc., to take care of COVID patients. So there's a complete emotional and physical exhaustion going on at this time in the healthcare force. A lot of people are saying, forget it, I'm done. And they are leaving medicine or nursing or radiology or whatever it is. A lot of people are retiring early. A lot of people are just giving up and sort of retreating for mental health issues. So that's happening right now. Then, because a lot of people are leaving, we're starting to use a lot of what we call staffing agency sort of staffing models. And these staffing agencies are basically predators that go after hospital staff and say, hey, I'll pay you 3 times what you're making here, and I'll give you easier shifts. And actually, if you come to Seattle, I'll pay for your lodging while you're there. So that's what we call traveling nurses. And that's completely breaking apart the staffing models in the hospitals, because hospitals cannot compete with those salaries or benefits or things like that. So we're sort of going to staffing models that are unsustainable, and we're losing really good nurses to those staffing models. And hospitals are filling back up. We're starting to see the sort of the very beginning of Omicron right now, with a just exponential increase in the number of cases in Houston last week. And we know that behind cases, we're going to see an increase in hospitalizations.
I think because a lot of people think, man, it's the hospitals are completely overtaken, but they're thinking of a fully staffed hospital. But some of this is just a fairly poorly staffed hospital that they can't take on patients. Is it more of that than a fully staffed hospital that just can't take on any more patients?
Yeah, we have really good data showing that any hospital in the United States, when it's in surge mode for COVID-19, outcomes are worse for patients. Again, not because we're doing anything wrong, but it's just complete overwhelming of the system. We don't have the normal people staffing the units, or we don't have the normal resources that we use. So there's all sorts of material and medication shortages anytime we go in the surge. So unquestionable, in Texas, everywhere in the United States, everywhere in the world, anytime a hospital goes into surge mode, outcomes worsen for everybody, not only COVID patients.
Doctor, one last question. Is there anything that people can do, vaccinated or unvaccinated, at their house to better prepare and boost their immune system in preparation for COVID or Omicron or whatever other variant that's coming our way? What can people do to better prepare?
Well, the good news is that the things that work for traditional COVID-19 work for Omicron as well. So, staying healthy, having a good diet, a good immune system, masking and social distancing and washing your hands work perfectly well against Omicron. And the problem we're having right now is that we, again, have a complete breakdown in the normal measures that we know work for COVID. People are done with masking. People are done with social distancing. There's very little of that going on. We're actively litigating against measures that are known to be life-saving. And that's the situation we're in right now.
Well, Doctor, we greatly appreciate your time. Hang on one second. That way we can get a picture. We like to take pictures of all of us. But anyway, we had a great time with you, and hopefully we can check it back in the near future.
No, these are great questions, and you guys are good interviewers. It's fun to do this, and I'm wondering how well this is going to age by January.
It'll be good.